Hello, everyone. Welcome to this episode. Shaun Brewster, joined by Bodine Ledden. Today, Bo, we're going to talk about radiculopathy. Now, radiculopathy is one of those things that's, I think, poorly managed a lot of the time, often misdiagnosed, and can cause all sorts of issues for patients that can be quite distressing a lot of the time. Um, Today, we're going to talk to our resident neuro guru. That's pretty hard to say. Bo. Bodine's absolutely an expert in all things neurological presentation. So, Bo, I'm going to interview you today and ask you some questions about radiculopathy that I think a lot of our audience would benefit from hearing. Some basic stuff right through to management, co-management, and so on. But I think that everybody could take something away from. So, are you ready?
Yeah, I'm ready. I wouldn't say I'm an expert. I've got a very special interest in this area, but yeah, I'll do my best.
A deep interest, I'd say. All right, here we go. So, firstly, let's start with the basics. Let's first of all define what a radiculopathy is for anyone who maybe isn't familiar with that term.
Yeah, and so I guess when we look at radiculopathy, so there's some form of impairment of conduction of the nervous system, typically occurring at the nerve root. And so when we talk about radiculopathy, again, it can be sort of a bit misunderstood as well because we've got a few things that might sit within that umbrella of radiculopathy, radicular pain, somatic referred pain. You can even have a painful radiculopathy. So when we're talking about radiculopathy in isolation, there is an impaired conduction of either sensory and or motor function of the nervous system, typically occurring at the nerve root. And so radiculopathy is not necessarily associated with pain. Okay, so there can be an absent or what's often referred to as negative signs, where there'll be decreased sensation or even decreased motor function or motor power. And so you can have the combination of the two as well, where there's decreased sensation and or decreased motor function. And so that would be radiculopathy.
Okay. And so then if somebody's presenting with something like paresthesia, which is not necessarily painful, but it's an altered sensation, that would be still a radiculopathy, but not a painful radiculopathy.
Yeah, well, I mean, it could be. It could be that it's coming. Is it following a neuroanatomically plausible distribution or of a dermatomal distribution? And there can be variations in what a true dermatomal pattern is, but it's got to be neuroanatomically plausible. But it could be coming from the nerve root, or it could be a peripheral neuropathy. So where there's just impairment of the sensory branch of that nerve. And so when we look at peripheral neuropathy versus radiculopathy, well, it comes back to a little bit more assessment as to where that impairment or where that conduction loss is coming from. And so with a paresthesia, so there would be impaired sensation. If you go back to the definitions of a paresthesia, it's something that would be described as not necessarily painful. So it's altered sensation, but it's not painful.
Sure. And I think that's a fairly common thing that we see clinically, right? And this might be where I think a lot of patients, a lot of therapists misdiagnose and potentially mismanage their patients. As the patient comes in and goes, I'm getting tingling down my arm, into my hand, into these three fingers. And we go, okay, that could be coming from a compression of the nerve somewhere along the path of that probably median nerve in this case, or maybe it's coming from higher up the chain in the neck. How would you differentiate those two?
Yeah, it's a good question, and it's a challenging one. Use the example of something like a carpal tunnel. How do you differentiate that from radiculopathy or radicular pain? Well, it does come back to a pretty good neurological screen to start with, and I think this is a good way to start in general, is to start with a good sensory examination. And typically, like a circumferential examination is a good way to start using light touch and sharp touch. So you're looking for basically, we're just trying to detect the response of different types of nerve fibers, from the large fibers versus the small fibers. And going circumferentially, so you might start quite proximal around the neck and then the shoulder, and working your way down elbow, forearm, and hand. And you're trying to map out an area where there might be impaired sensation or a change in normal sensation that could also be compared to the other side. So that's a good way to start with sensory examination to see if you can map out that location. Is it neuroanatomically plausible of a dermatomal distribution, or is it, more likely that it's a peripheral nerve? And so that's just assessing for the sensation, but then you would need to look at, well, is there impairment of the motor component to this nerve? And so that's where your muscle power testing would be important. Um, so using a muscle power examination and looking for strength deficits or impairments from one side to the other. And that can give us a little bit better idea of the spinal segment that this may be occurring at if it's centrally driven. And then go into a reflex examination, which assesses that spinal segment. So for example, you might assess the biceps tendon reflex at C5, 6. And so you're assessing how well that pathway is functioning. So you'll have sensory afferents from that muscle spindle that are going towards the central nervous system to the spinal segment, where you'll have a monosynaptic reflex that will excite a motor neuron traveling along an efferent pathway to excite the muscle. So will result in a reflexive contraction. At the same time, there will be inhibition to the antagonist muscle. And so really that's just seeing how well the sensory and motor nerve pathway is functioning at that spinal segment. And so you can use a reflex assessment at C5, 6, at C6 at brachioradialis, and C6, 7 at the triceps tendon. So it gives you a little bit more information. And obviously none of these tests in isolation are very robust or have a lot of reliability. We've got to cluster these together, and that's why it's good to have this bit of a process. And so after you've done a reflex assessment, and then you might look at neurodynamic assessment. And so what you're looking at with a neurodynamic assessment, and this would be something that most people are fairly familiar with, different ways to assess, say, like a median nerve. If you're listening to this, sort of like holding a plate above your head with your wrist extended and your elbow flexed. And then if you straightened out your arm, extended your elbow while maintaining extension of the wrist, that would be a median neurodynamic test 1. And we're just seeing, is that sensitive? Does that reproduce those familiar symptoms? We can be a little bit more specific with this in different types of neurodynamic tests that might bias the median nerve more, or the radial nerve, the ulnar, or the musculocutaneous nerve. And then there's different approaches that you can take with sensitizing additions and desensitizing additions to see if we can narrow this down a little bit more. And obviously, as I said, this assesses nerve mechanosensitivity to see if the nerve is sensitive. Now, if it's just a radiculopathy where there's a conduction loss, you may not have a positive neurodynamic test, but that doesn't mean that there's no impairment of the nervous system. So that's a good way to start. You could also add on some extras like nerve palpation. So palpating the nerve in different areas to see if that is most sensitive. And for example, in a carpal tunnel, if the compression and the compression was occurring in that carpal tunnel, well, typically you would expect it to be more sensitive to palpate over where that compression is occurring, and maybe a little bit less up in the cubital fossa, and maybe a little bit less, at the brachial plexus. Whereas it might be the other way around in radicular pain, but that's not always with 100% certainty, but it can give you a little bit of an idea when you start to put all of this together.
Yeah, great. And so you touched on this idea before about neuroanatomical plausibility. And I think a lot of those things you're just talking about there comes down to understanding the structure and the components of the nervous system. So to be able to conduct a neurodynamic test, you have to understand, the pathway of the nerve that you're assessing, so that you can then lengthen it, tension it, and try to bring on some symptoms. Likewise, if you're trying to palpate a nerve, you have to understand the pathway of that nerve. Likewise, if you're doing sensory or motor testing, you have to understand the function of those nerves and how to elicit a response from them. So it all makes sense. Coming back to this thing that we often talk about, which is understand your anatomy well. And so if you're listening to what Bo's saying and you're thinking, wow, that's all go over my head, take a step back. The only thing you then have to understand to be able to understand what he's saying, what you're saying, Bo, is the structure and function of the nervous system. You'd start with that, and then there's the door opens. And then once you step through the door, then you can understand how to work with each of those structures and each components. I like the idea of that neuroanatomically plausible explanation. It really is like, okay, let me capture the data here. Let me capture all the information that I've got and try to understand why this person's presenting with these symptoms. And which brings me to my next question, which is the things that a lot of clinicians might confuse with the radiculopathy. And, for someone who doesn't understand the neuroanatomy well, if a patient comes in and they say, look, I'm getting this pain across my neck and sort of down my arm. And you go, okay, sounds like a nerve compression somewhere in the neck, maybe going down the arm. Let's work on that. But that's such a superficial kind of view of it, because you can also have pain that goes down the arm from a heart attack, right? And you could be working on someone's scalenes to try to decompress a brachial plexus because that's what you think it is, when in actual fact they're in the process of having a myocardial infarction and you need to get them to a hospital. So understanding the differences between radiculopathy, peripheral nerve compression or irritation, and then somatic referred pain, visceral referred pain, all these other things. What are some of the things that somebody could confuse a radiculopathy with? And then what are the potential dangers with that?
Yeah, you're right. It's not always clear. It's not always textbook. When you see the posters that are on the wall in most clinicians' treatment room, these clear dermatomal patterns. They often don't present that way. In fact, it's probably more normal not to match that typical dermatomal distribution. And so we know in cervical radiculopathy that the most common dermatomal pattern that would match the spinal segment as far as their symptoms and the segment involved is C4, and in the lumbar spine is S1. And so outside of that, there's a lot of overlap between different spinal segments. And you think about, well, we've got a plexus. All right, and that can vary from person to person as well. There's a number of morphological variations that can occur there. But, when we look at pain and pathology, we can't use pathology, or we can't use anatomy as a pain map. It's like that structure and pain are two separate things, and so we've always got to keep that in mind. But you might have more of a patchy presentation. So, for example, in spine-related leg pain or a lumbar radiculopathy or radicular pain, there might be more of a patchy sensation. So that there might be symptoms in the quad and then in the leg, but it might not be like this specific line running down the leg. So that to go back to your question, that sometimes can be confused to be myofascial in origin. And a classic example in cervical radiculopathy, about 50% of cases will present with interscap pain. And so when you think about that, how many people present with neck pain and sort of they might complain of this pain in their rhomboid or around their scapula or even their trapezius area? Well, that could be that could be associated with radicular pain. And then when you think about these blurred lines of the sclerotome, the myotome, the dermatome, the convergence of multiple sensory afferents onto a second order neuron. So where these different innervated tissues will come together with their afferent information. By the time that information makes its way up to the cortex and the interpretation about where the location of those symptoms is coming from, it can be a little bit blurry. But then, you add on top of that someone that does have some pain, and there might be some changes that go with that, some changes in movement, some guarding, some muscle spasm. And so there could also be myofascial referred pain that goes with that. And so while most commonly we'll see neuropathic pain that might present with, lancinating symptoms. It might be pins and needles, altered sensation. You can also get this muscular aching sensation. And what's really interesting about that is to remember that nerves are covered by connective tissue lining. And so that tissue is also innervated by a nerve called the nervi nervorum. So the nerve is innervated by a nerve, but also that tissue can become sensitized, and that can also contribute to aching sensations. And so that's also something to keep in mind, as well as the myotome muscles nerves that are innervating muscles, they can become sensitized as well. And so there's that aching, diffuse, non-specific pain. And so it's important to go through a good neurological examination to see if there is a component of radiculopathy. And sometimes there might be a small component, sometimes there might be a much larger component, but it can be overlooked and looked just through the lens of myofascial referred pain. And while that may contribute, there could be some other underlying contributors. And just to add to that, sometimes these changes can occur very slowly over time. So it's not like with radiculopathy that it's usually always a traumatic event. While that certainly can happen, there might be some age-related changes, some changes in the foramen where that nerve root exits. There could be some, changes in disc height. There could be some, osteophyte formation. There could be changes to the disc and the way that it sort of protrudes or encroaches into that space where the nerve exits, and that could cause some of these progressive changes. That sometimes the nervous system completely adapts and it's also fine, but you might start to see some of these changes in sensory and/or motor function.
Okay, good one. So that sort of half answered my next question around the different causes of particularly painful or symptomatic radiculopathies. You talk about discs, you talk about, bony osteophyte formation, other sort of encroachment on the nerve. What's the long-term outcome, medium to long-term outcome for somebody who doesn't manage that well? So they've got symptoms and they just put up with it and get on with life. What's the fallout from that, or potential fallout?
Well, it's a hard one to answer, but we know that most cases of radicular pain resolve within about 3 months. Some people do go on and have persistent symptoms, but I think for those that where there's no severe neurological deficit, it's not progressive, where we can start to see some changes early on or some improvements, the prognosis for those patients is usually pretty good. And so if you did absolutely nothing, for example, in cervical radiculopathy, 85% of the time, people will get better within 12 weeks. And so it really does depend on the person and other factors that may be contributing to their pain, and also the level of activity that they're doing throughout that time. One of the best things is providing advice to remain active during that time. Obviously, it can be a very scary time for patients. There can be a lot of fear that's involved with that, which may lead to avoidance of movement and behavioral changes. But if we can provide reassurance to our patients to say, look, yeah, it is very sensitive, but the good news is we've ruled out any serious pathology, and you can do that by conducting a very thorough history and a very thorough neurological screen. And in that time, you can adopt that watch and wait approach, where as long as we're starting to see some progressive improvement within that first 6-week period, then often they will have a very good result. So yeah, it's a tricky one to answer, but if we do start to see any progressive, if there's a severe neurological deficit, so they can't really contract against resistance, the symptoms are worsening, there's any abnormal reflexes, that might suggest there's more central canal compression or there's any loss of bladder, bowel, sexual dysfunction, those types of things, then absolutely they need to be referred on. But in a lot of cases of radiculopathy, a painful radiculopathy, conservative management within the first 12 weeks is usually the first choice treatment option.
And that would be such an important thing to convey to the patient, even at the very beginning, and say, look, before we even get started, here's some interesting facts for you that you might like to know about, because it can give them some opportunity of like, oh, maybe I'll be one of these people. There's opportunity for hope, because I think a lot of our patients will find themselves in the situation of being, of presenting with neurological symptoms, and they'll immediately go to the worst case scenario, they'll know someone who's had, like a really debilitating sciatic pain or something, historically in their family, and it took them out of work for years at a time. Like there's always a worst case scenario somewhere in their story. And so how important is it then, given that a lot of people will think in this very pathoanatomical kind of structural cause, like there's something squashing the nerve, I've got degenerated discs, I've got an osteophyte, I've got a bulge, I've got a whatever. How important is imaging in that scenario, or in any scenario when a patient presents with neurological pain, or
Yeah,
radiculopathy in particular?
well, I think yeah, it's certainly a good question, and often from a patient point of view, let's say they've got an acute radiculopathy, um, which just reminds me, maybe we'll go back and talk about radicular pain as well. But let's say they've got an acute severe neurological deficit. Assessing the severity of that is really important. So if it is severe, there is a severe loss of motor function. If it's progressive, so it's getting worse, or there's suggestions that it may be polyroot, so several segments may be involved. So there might be neurological deficit in knee extensors, plantar flexors, and also in knee flexors as well. You might start to think there's several segments that may be involved here, or there's a significant trauma. So a traumatic event like a car accident or something like that, then, or they've got a family history of cancer, or there's any suspect of something's not quite musculoskeletal here, something's not quite right. This needs further examination, then absolutely they need to be referred on. Or if you're thinking this is a little bit beyond my knowledge, I'm really not sure, then they also need to be referred on. But when we look at imaging for radicular pain or radiculopathy, it can have significant downstream consequences. It can lead to more surgeries. It can lead to more opioid use. It can lead to larger financial cost for the patient, and sometimes worse outcomes as well. But when you look at the pathology behind what causes most radiculopathies is herniations, disc herniations in most cases, and so what we do know about that is that in a lot of cases they can resolve, and in fact, the worse that the disc injury is, the better the prognosis. So when you look from a herniation to an extrusion to a sequestration, those that have a sequestration are likely to have a better prognosis. And why it may be so painful is there's increase in inflammatory mediators and sensitizing substances around that nerve that can cause a lot more pain. So it's important to understand that, but even in some cases as well, when you look at imaging, there's studies that'll show that at 10-year follow-ups, symptoms can change even without the disc changing. So there can be some compression of a nerve that may be symptomatic at the time. But what do we know about our body is that it can adapt. You see this in more severe spinal stenosis. In fact, people that have more severe spinal stenosis, that not all of them will be symptomatic. And so, again, we can't always associate the symptoms with pathology. So that's where imaging can sometimes, it needs to be interpreted within the context of that patient, and it's a snapshot in time. Because we can see changes that occur to the disc. We can see an absence of changes that occur from a pathological point of view, but symptoms can significantly change and improve. And so I think that's always important to be conveyed to our patients. But that's why a really thorough assessment is important so that we can match those clinical findings with the patient's symptoms and then imaging findings, because none of those in isolation should really be used.
Yeah, right. Okay. So if we then take the classic patient who's not surgically indicated, there's no obvious structural source of the problem that can't be resolved through other non-surgical means, um, what would be the most obvious and clinically regularly used applications that we might use to help this person with their symptoms, whether it be painful radiculopathy or just radiculopathy?
Yeah, I think we've just got to look at the person as a whole once again. Like so much of our treatment is just to get people moving. And so from a manual therapy context, often it can be very useful in that short term to take away some of the fear of movement. And so you might treat the muscles locally to calm some of that protective spasm and guarding, plus the contextual effects that might go with that. Coaching someone on how to get that nerve moving and less sensitive. Because if we look at what's going on at a neural level, when there is compression of a nerve, there can be deprivation of blood supply and oxygen, and therefore that impairs its ability to conduct action potentials. And so the impaired ability to send messages to or from the nervous system, that can lead to changes in and around the nerve that can increase intraneural edema, so swelling within the nerve and around the nerve. It can attract other pro-inflammatory mediators and neurotransmitters that can sensitize that nerve. And so when you think about it like that, well, neurodynamic mobilization, and even if we could just get the person exercising, the effects that can have on their systemic health, their stress, their overall well-being can decrease the overall level of sensitivity of the nervous system. We know the health benefits that are associated with just general exercise. They can also influence positive behavioral changes and decreases in pain. But if we look then from the viewpoint of the nervous system specifically, well, that movement can create dispersion of intraneural edema. It can increase local blood flow and oxygen that can promote improved health to the nerve. And so doing that progressively and consistently over time can lead to some positive changes to the nerve and the function of that nerve. So I think it's important to look at it like that. And as I said, from a clinical point of view, manual therapy base, you can use that in the short term to decrease symptoms, to promote some active movement. And then we've just got to coach them over time to progress that, because nerves will adapt to applied stimulus. They're a lot slower than muscles and ligaments may adapt, but they will adapt. And it's just providing the right environment for that nerve to adapt that we can aim to decrease overall disability and dysfunction or impairment, and decrease the person's pain.
Yeah, okay, right. And I think if you're a manual therapist listening to this, without understanding all this quite well, it would be very easy to fall into the trap of saying, well, okay, what manual therapy skills have I got? Like what I'm going to hold a hammer. I need to find a nail. We'll use that analogy quite a lot. But if someone presents with neurological pain, so painful radiculopathy, if it's a painful muscle, well, I rub it, I squash it, I squeeze it, right? So if it's a painful nerve, maybe I should rub it, squash it, and squeeze it, right? And this again comes back to understanding our pathoanatomical causes of pain and presentations. And if a lot of these neurological pain presentations, or even altered sensation and altered function of nerves, comes on as a result of nerve compression, and then providing more compression seems counterintuitive, but it's very easy to see how a lot of us might fall into this habit of going, well, I've got these two hands and I've got a whole bunch of tools that I use here. So I'll apply those, because typically when I apply those to somebody's pain presentation or symptoms, they get some benefit. But we have to remember the nervous system is not like a muscle. The nervous system is not like a piece of fascia or, even, ligaments, tendons. It's all all these things are very, very different. They respond differently to different types of input. And the nervous system requires mobility. It requires circulation. It requires the ability to be mobile, I guess is probably the best way to put it. And so if we're providing compression, we're sort of stopping that mobility to a degree. And so your manual therapy techniques, like you said, can be used strategically to modify symptoms to improve the ability for then the person to move, to be able to actually provide more mobility for that nerve, to encourage the nerve to glide and slide through tissues, to support that lymphatic process that you were talking about before, to encourage greater degree of circulation, because we know nerves are very thirsty. They require a lot of blood and oxygen. So all of these things require us to understand the anatomy and the specific requirements of that anatomy. And then we can selectively choose which tool we use or which technique we might use to benefit that anatomy rather than just throwing something at it because that's all we've got. And this is what I'm probably saying, this is more erring caution in people, in that we have to think before we do, because so often we'll just do what we've always done without considering what is the real need of the individual patient contextually, but also the structures at play within that patient's presentation. And that can vary dramatically.
Yeah, and again, that comes back to sort of an accurate assessment because, like a classic one that sort of grinds my gears a little bit is the whole piriformis syndrome. And when you look at the research, as far as we know, that most presentations occur or sort of radicular pain symptoms from the lumbar spine. Um, Not to say that piriform syndrome, or what's currently referred to as deep gluteal syndrome, doesn't exist. It's in a very small percentage, but firstly, we've got to rule out the lumbar spine. But um, at the level, the radicular pain that occurs at the level of L4 often presents as buttock pain in most cases. And so it would, when you think about the lumbar sacral plexus, that will then travel through or exit through that greater sciatic foramen under the piriformis through that deep gluteal space. Yeah, it might present as buttock pain, even though that the symptoms are actually being driven from the lumbar spine. And one thing that nerves don't really like, especially when they're stirred up, is compression and stretching. And so often, put this tennis ball in your glute area and roll around on that, and then stretch your piriformis out, and this will resolve your sciatica. And when you think about the mechanisms of that, well, maybe that could work for some people, but the underpinning neurophysiology here is providing more compression to a nerve could potentially increase sensitivity of the nerve. It could deprive it of more blood and oxygen. And in fact, the longer that we leave nerves at stretch for, it impairs the ability for blood supply to enter through that nerve and deoxygenated blood to leave. So it can lead to sort of this venous backflow and essentially limited oxygen to the nerve, which could potentially change the pH in and around the nerve, and its upregulation of pro-inflammatory chemicals and neurotransmitters, and therefore it becomes more sensitive. And so even though the symptoms might present in the buttock, and we even see this in radicular pain, where the leg pain is typically worse than the back pain. And so would you get a benefit from just rubbing through the leg? Well, maybe, but you might get a better benefit from going and treating at the spinal segment. And that's the importance of the assessment, is to trace it back to where it's most likely, where most likely that the contributors are, or the drivers of those symptoms are coming from.
Brilliant. Yeah, look, there's probably a lot of people listening or watching this thinking, okay, this all is sort of making sense, but there's some gaps in my understanding or my knowledge, because very few of us, and I think Bo, you and I included, went through our undergraduate training, whether it's diploma, advanced diploma, degree, master's, doesn't matter, coming out the other side of that going, I know how to effectively assess and treat neurological presentations like a pro. Nobody does that with their undergraduate. You sort of have to do your own development, your own reading, further study, usually, to be able to do this stuff really, really well, unless you've gone through a program that maybe specializes in that. And so for those who are listening to this going, yeah, cool, okay, I'm getting a bit of an idea, but then a patient walks through their door next week and they can't necessarily put all the pieces of the puzzle together on the spot. They have to go away and do some more study. Who would be the best point of referral for something like this? Or what kind of practitioners should we be sort of handballing these patients to in the meantime, while we're either developing our skills, or if the patient presents with something that's beyond our scope?
Oh, it's a good question. It's a hard one because it really does depend on your level of training, the other clinicians that are around in that area. Um, I think the first thing would be just to really develop your own base of a good understanding to start with. If you've got a good network of other clinicians around, it could be other good physios, neurophysios, sports docs. It could be other myotherapists. It probably doesn't necessarily come down to a specific practitioner. It probably depends on where that interest lies. Um, I guess one thing that you've got to be mindful of is completely contradicting opinions. And if whenever you refer anyone out, and if they look at it through a very different lens and go, no, it's not like that. Well, it just adds a lot of confusion to the patient. Plus, if you're adding in more diagnostic labels, um, again, that can add to some more confusion. And the influence of that, it basically can just increase the patient's level of stress, fear, anxiety, worry. This is never going to get better. Pain starts to increase. So yeah, it's a difficult one. I think refer to someone who does have robust knowledge in this area or that specializes in neuropathic pain, and see if you can develop a bit of a network. But in the meantime, start to dive into this a little bit more and understand it a bit more, because I think it's one of those topics that someone comes in with nerve pain. A lot of clinicians will really panic and think, oh my God, I don't even know where to start. It doesn't look like it's supposed to look like. And so breaking it down into those smaller chunks and performing a good, robust assessment is key. Because even if you don't know where to go from there, at least you've got a good understanding. And if there's any abnormal signs that are going with that, you think, you know what, this doesn't sound right. I've got to refer you on immediately, or with less urgency, depending on how severe this is presenting. Um, yeah, hopefully that sort of answers that question a little bit.
Yeah, and I think your point about not necessarily picking a modality, so you wouldn't necessarily choose a physiotherapist or an osteopath or a carb. It doesn't matter what the modality is; it's the individual practitioner, right? Do they have that special interest? Have they invested time and effort in getting good at that thing? Like for yourself, like this is mostly self-taught, and you've done some additional study as well. You pick up these skills, knowledge over time because you got a real deep interest in the thing. And that's a beautiful piece of advice you gave there, is build that network of practitioners who are really good at certain things. Like we can't all be good at everything, right? And so you want to find the best person for all these different things so that you can refer, and that network starts to refer back to you for the things that you're good at. So this is good interprofessional communication and networking. And that's really the best thing for the patient, because I've had a lot of patients over the years who have come to me for years for various different things on and off, always assuming that I'm going to be able to help them because I've helped them in the past. But the next thing they present with might not be something in my wheelhouse. And I've got two choices. I can kind of go, look, let's give it a go, you know, or I can go, you know what, I'm probably not the best person, but I know who might be. And let's get you to them. And that is going to get you a faster result and a more efficient outcome. And that's the best thing for you. You won't lose the patient. They'll respect you for it. They'll go and get the result they want. And they'll come back to you for the thing they came to you in the first place. And that's that beautiful thing about interpersonal respect. Like you mentioned before about, contradicting another person's diagnosis. You don't always, you might believe it to be something and then you tell the patient it's something else. And then that, like you said, they get a little bit lost. Like, well, I trust this person over here, but I also trust you. And how can both things be true? And so having that network of people that you can rely on for really good quality information and resources and advice uh, helps to give your patients a sense of certainty as well as they get moved between from one person to the next person that is the right person to see them, rather than a handball just because you don't know where to send them. And I think that's really important.
Yeah, and it probably, comes back to patient preferences as well. Like, I think every practitioner has a role, but it's just understanding that role. Like, someone with more severe neuropathic pain might benefit from just a good flush, a good relaxation, just to calm their symptoms, not being very specific, just a very general treatment, to manage those symptoms so that then they can go and see the other modality for more specific treatment or mobilization or exercise. And so that co-management can work hand in hand. So it's not that you need to do everything, but it's just playing your role within multimodal care is super important.
Yeah, brilliant. But I think this has been useful. We've dived pretty deep into this stuff, and for a lot of people, there'll be some new terminology, some new concepts, and um, I can't recommend highly enough, and I know you believe the same, that you go and learn this stuff. Like really start to develop an understanding of the nervous system. You don't have to become an expert, but know enough to not be dangerous. Know enough to be able to pick out the things that are a red flag or something you need to refer on and be able to go, actually, that what you're presenting with there, I don't know how to help you, but I know what it is. And so I'm going to get you to the person who can help you with this. And so that's an important thing. And I guess it's a little plug for us here, but it's why we have our neuro assessment and treatment course, right? It's why this thing was developed because we saw so many people that had this gap in their knowledge that needed to have it filled so that they can help more patients or co-manage them with the right people.
Yeah, and that's the thing. Like, not everything is mechanical too. There can be more serious things, more sinister things
Mm,
that might masquerade as musculoskeletal or neurological pain. And so, just having that bit more understanding about what is my list of differentials that I've got to consider? Because even though I said before that, ruling out serious pathology, you've always got to keep that as a consideration. You've always got to have that on your differentials if these changes aren't going according to how you sort of think they could or should, always considering what have I missed here? Is there anything else that needs further investigation? And in a lot of cases, you'd rather be have that extra level of certainty.
for sure. Brilliant, Bo. I think we'll wrap it up there. Thank you, everyone, for tuning and listening to this one. Thanks, Bo, for your insights and information as always. And we'll talk to you all soon.
Cheers.